Education Conference, coming live to you from Sofitel, San Francisco. And may I ask the folks here in this room to please turn off your cell phone for the rest of the day because it may interfere with the live streaming process. And so we ask you to turn it off completely if you can. Okay, I'm going to start over again. Scott, are we ready to go? Okay. Welcome to the CFRI's 26th National Cystic Fibrosis Education Conference, coming to you live from the Hotel Sofitel in Northern California. This is the last day of our 3-day conference. Welcome to all online attendees. I'm pleased to introduce our first presenter, pharmacist Kathrine Yang. Ms. Yang is a clinical professor of pharmacy at the University of California, San Francisco School of Pharmacy. She received her doctorate of pharmacy from UCSF, where she also completed her residency and fellowship in infectious diseases pharmacotherapy. She received her master's in public health from UC Berkeley. Ms. Yang's area of expertise is in the treatment of multi-drug resistant organisms, such as Pseudomonas aeruginosus. She will discuss best practices in CF infection control. Please give a warm welcome to Ms. Yang. Welcome.
Thank you so much. Thank you for that very warm welcome. Let me see if I can hook myself up here. Okay. So thank you for everyone for inviting me here, and welcome to everybody who's watching online. Today I'm going to talk about infection control and best practices. Let's see if I can find my slides here. Oh. Oh, that's not it. Here, oops, that's not it. Not in the right place. There we go. Okay, so the title of my presentation is Should We Live in a Bubble? And Best Practices in Cystic Fibrosis Infection Control. So as a disclaimer to everyone out there, I just want everybody to know that yes, I am a germaphobe. By virtue of what I do in the hospital, I treat patients with multi-drug resistant infections. I see all the weird stuff that you don't normally see. So if you ask me to treat an ear infection, I probably wouldn't be able to do that. But if you ask me to treat a person with multi-drug resistant Pseudomonas growing out of lungs or out of their brain or something, I could probably handle that. But ask me about something like an ear infection and I probably won't know. So I am a germaphobe. Everything that I see is weird. And because of that, I think it's normal. And like I said, I'm really fastidious about hand gel, and I'm really careful about germs because of what I see. I think all of that's normal. So the objectives today is we're going to talk about the major pathogens associated with infection in patients with CF and where they naturally reside. And that's important because if we know where the infection is coming from or where the organisms normally live, we can look at ways to sort of prevent infection. So one thing I want to make clear is there's no way we can absolutely keep everybody infection-free. There's just no way. And it's really going to be a balance of what you're willing to tolerate versus what you're willing to do. And that's a lot of what we're going to be talking about today. We're going to talk about the current and upcoming cystic fibrosis infection control guidelines and really discuss some common sense approaches to infection control at home and in the community. So we're not really going to talk about hospital, but what you can do living at home and in your community and in your normal environment to stay safe. And lastly, we're going to look at proper techniques for hand washing and the use of alcohol gel. We may not get to the hand washing part, but I really want to show you the video on alcohol gel, just because I think we focus so much on technique for hand washing, but no one really talks about alcohol gel, and there actually is a technique involved in that. So this is your environment. If you are a person with CF, you have to manipulate all these different bubbles. You have the natural environment, so soil and dirt and water. You have your non-cystic fibrosis friends and families, and you have your cystic fibrosis friends and family. All of these are very rich and important parts of your life, but also can be different sources of infection. So you're right in the middle of this, and we're going to talk about ways that you can manipulate your environment to help you stay safe. So these are the current cystic fibrosis guidelines, and these were published in 2003 in Infection Control and Hospital Epidemiology. And I'm sure most of you have actually seen these guidelines. And so these guidelines look at ways to prevent infection up to 2003 and what was known then. Of course, that was 10 years ago. So there are other guidelines in place. CF Foundation has their own infection control and policy guidelines, which were updated in March of this year, and they're based on these ICHE guidelines that were published. And of course, CFRI also has infection control policies which you adhere to in order to come to conferences like these. But again, this guideline, which is the main working guideline, is 10 years old. So there are new guidelines coming out, and these are expected to come out later this year. So initially it was September of 2013. It may actually be a little bit later than that. And one of the main things I think will be important in this guideline are new recommendations regarding distance in terms of transmission, so how far you need to be from a person. And between now and 2003, there was a lot of new information on staph. So Staph aureus and MRSA has become a big problem in the community, not just for cystic fibrosis, but for everybody in general. So there are new guidelines and new information regarding staph, and also influenza, because again, between 2003, we had SARS, we had influenza, we had swine flu, we had avian flu. So those are also rolled into the guidelines. And I think this set of guidelines also takes into more information from other governing bodies, such as Society of Healthcare Epidemiology and CDC. So those will also be rolled in together. And in any instance where there isn't any specific cystic fibrosis guideline, then the prevailing guideline for the general population will prevail. So before we get started, I wanted to go over some general infection control terminology, and I think this will help you understand where sort of these precautions come from and help you interpret signage when you go into the hospital. Standard precautions applies to everyone. This is the most basic one. And so the main thing I want you to get from this presentation is most infection control guidelines apply to everybody, not just cystic fibrosis. So for standard precautions, they apply to any patient in any situation. So whether you come into the hospital because you have a CF exacerbation, or you broke your leg, or you have a sprained wrist, it doesn't matter. Standard precautions always apply. And basically what that means is you have to have adequate hand hygiene at all times. Use your hand gel, wash your hands, gel in, gel out every time you go into a room. And in between patients, the surfaces and the rooms, the equipment is always going to be disinfected and cleaned. So that's standard precautions. This is just always for every person. And when necessary, personal protective equipment, or PPE, is used when there is any anticipated contact with body fluid. And the PPE that will be used will depend on sort of what the risk is and what the route of transmission is. And of course, cough etiquette, so covering your cough, wearing a mask if you have any type of respiratory symptoms. So what is PPE? This is not PPE. This can be PPE. So PPE is meant to reduce exposure to germs for both the person wearing it and for people close by. So whenever you watch ER or these, drama shows, you see people all gowned up, and you always think, okay, it's protecting the person that's wearing it. And that's true, but it's also meant to protect the people in the room. So for instance, if you have a healthcare provider coming into the room, and they've been wearing the same set of scrubs for the whole day, you can imagine that probably, if you're the last patient, that might not be the cleanest set of scrubs. And I doubt if they'll be changing their clothes in between. But if they wear a gown over, that's protecting them from you, but they're also protecting you from them, okay? And PPE can include gloves, gowns, masks, goggles, and face shields. And goggles and face shields are really used for any time there's a splatter risk. So the next level up in terms of precautions is contact precautions. And contact precautions is the most common way to have precautions because the most common way to transmit germs is through touch. So, and it doesn't necessarily have to be touch between a person. It can be touch with an inanimate object such as a microphone or a cup, etc. So direct contact transmission occurs by actual sharing secretions. So that would be respiratory secretions such as from kissing or even blood. So anytime there's a direct contact, that would be considered direct transmission. There's also indirect contact transmission, and that occurs when you're touching anything that's in the environment. So again, if you're holding a toy that is passed around between kids, shaking hands, which is why we have the rule that you should probably avoid shaking hands if you can. We've often joked in the ID rule that we should just ban handshaking altogether and do something like an elbow bump, my elbow to your elbow. So that prevents any type of touching between people. And things like nebulizer, touching things that are contaminated, also can cause indirect transmission. High fives. So we don't think about that, but this is definitely a source of indirect transmission. And if you have children who play sports, does that mean you don't allow your kids to high five each other? Of course not. I mean, that's part of the game, it's part of the sport, it's part of the fulfillment of that. But hand hygiene, of course, would be important. So if you're going to be doing a lot of the high fiving and dog paddling or whatever, hand hygiene is always important. So the personal protective equipment involved for contact precautions would be always having clean hands. So clean hands applies to everything, right? No matter what type of precaution. Always have clean hands. And because it's a touch risk, gowns and gloves would also be important. Droplet precautions. So the next two get a little bit confusing. You have droplet precautions and you have airborne precautions. And this is for stuff that is in the air. Droplet precautions apply to infectious droplets, and those are things that tend to be a little bit bigger. Might be you would think of in like a spray bottle type scenario, and you can see here, with a sneeze you get quite a bit of that. So it's anything that's formed when a person coughs, sneezes, spits, even singing. Opera singers, of course, or undergoing respiratory procedures. So if you're doing a nebulizer treatment, or you're doing a bronchoalveolar lavage, or you're giving a sputum sample, any of that can lead to droplets. And droplet transmission occurs when the droplet that's sprayed into the air touches any one of your mucous membranes. So it's not something that's necessarily inhaled, but something that touches your eyes, your nose, or your mouth. So anything that touches a mucous membrane. And droplets can travel as far as up to 3 to 6 feet, which is why we have this sort of 3 to 6 feet rule. So the personal protective equipment for this would then be a face shield or a mask, and a mask. So in this case, you have a face shield, or you can have goggles, and that's to prevent the spray into the eyes, because you can imagine that would be a source of transmission. And so the most common things you would think about getting through droplet precautions would be things like respiratory viruses, influenza, croup, any of those flu-type bugs can be transmitted through droplet precautions, which is why you always see, during flu season, you always see signage that says, don't rub your eyes, because you could definitely transmit it into your eyes. Airborne precautions. So airborne precautions is similar to droplet precautions in the sense that it's something that's blown into the air, But these tend to be smaller particles, and because they're smaller particles, they travel much farther, and they can travel long distances and be suspended in the air for quite a while. Think of pollen blowing into the air. If you ever see pollen sort of just flying through the air, or dust, that's exactly what we're talking about. The way it's transmitted is the same. So coughing, sneezing, spitting, singing, etc., all can cause these airborne nuclei to be suspended in the air. And they, again, can be carried on air currents for a long time and on dust particles. So because this type of transmission occurs by inhalation, this only requires a mask. It does not require a face shield. And it can be either with a paper mask or the sophisticated N95 masks. And for patients that are hospitalized under airborne precautions, these would be for things such as like tuberculosis and some other strange bugs like mumps and chickenpox also can be spread through airborne precautions. Patients will go into specialized negative pressure rooms where when you open the door into the room, the air actually doesn't blow out. The air actually is sucked into the room. And that's to prevent anything from blowing out into the hallway. And there's actually a set number of air exchanges that occur in the room. So the air inside the room is changed out on a cycle, and that can be up to like 6 to 12 air exchanges per hour, meaning that the entire air in the room is changed out every 6 to 12 minutes. So now we're going to talk about the major germs in CF, and these are the ones we'll be talking about. We won't be talking so much about respiratory viruses, but we'll focus on the top 3. And I'm sure you've all seen this graph, and this is a graph that was published by the Cystic Fibrosis Foundation. This last data is from 2011 showing the respiratory germs by age. So you have the percent of people with CF here on this y-axis and the age on the bottom axis. And the things that strike me when I look at this graph is that most people, by the time they reach young adulthood, in their early 20s, will have Pseudomonas, either as a chronic infection or colonized. And the percent of people with multi-drug resistant Pseudomonas is about 20-ish%. The other thing that really strikes me is this really huge uptick in staph. And again, we're going to talk about staph because it's become quite a problem in the community, not just for cystic fibrosis, but in general. And MRSA is on the rise. The good news, I think, is Burkholderia, even though we get really crazy about Burkholderia because it's such a horrible organism, the incidence is actually fairly low and stays fairly low throughout age. To me, that's very encouraging. So the first organism is Staph aureus and MRSA. MRSA stands for methicillin-resistant Staph aureus, and that's the one we always worry about. So these are guidelines that are really going to apply to everybody because Staph aureus is really non-discriminatory. It doesn't care if you have cystic fibrosis or not. It can be easily transmitted back and forth. And it's actually a common colonizer of your skin, meaning that it just lives on your skin and it lives in your nose, your armpits, and it can be part of the normal flora. So colonization is an important risk factor for infection, meaning that a lot of people who get invasive staph infection later on, they're found to actually carry the staph already on their body, either in their nose or on their skin. So typically when they get invasive infection, it's from themselves. You can also get it from the community as well. And historically, it's been associated with healthcare-associated infections, meaning it's something you would get if you went to the hospital. So you're hospitalized. The hospital is the worst place to be in terms of germs. That's why I'm a germaphobe. And, staph is everywhere. So, and people can get pneumonias, bloodstream infections, and one of the main problems is surgical site infections. So after you have surgery, getting a staph infection on the incision site. Lately, I would say in the last 10 years or so, there's been an uptick in what is called CA-MRSA, or community-acquired MRSA. So this is MRSA that you don't get from a hospital, and people who were getting this were people who had actually never been hospitalized. It was just in the community. And it was also methicillin resistant or drug resistant, and that's a problem. The good thing is, unlike the hospital-acquired or healthcare-associated MRSA, these tended to be, even though they were methicillin resistant, they were still treatable with oral antibiotics, and they were not as drug resistant. And the sites of infection were not so serious. It's usually sites of trauma on the skin, on the hair follicles. So not invasive infections, but typically skin infections. So there have been numerous reports, especially in the lay press and also through the CDC, of community-acquired MRSA outbreaks in the community. And this is probably the most famous one, clone of methicillin-resistant Staph aureus among professional football players. Anybody heard of this? So there was, in 2003, the St. Louis Rams, in their training facility, had an outbreak of a cluster of MRSA skin infections in their football players. And CDC went in to investigate. And what they found was these were due to turf burns. So people who would be playing on artificial turf, they would get scruffed up on the turf, they'd break the skin, and you'd have an open sore. And those would become infected, and they would get abscesses. And when they did the investigation, they found there were certain risk factors. Linemen and linebackers tended to have more infections, probably because they were up in the front and more likely to have that contact and scruffing on the turf. But when they went and did environmental investigations in the locker rooms, other risk factors were dirty whirlpools. I mean, they were just gross. They didn't have good sanitation in the whirlpools. Sharing equipment, so workout equipment, sharing towels, and they found that some towels had been passed between multiple people before they were washed. And we think about them like, oh, that's so gross, but that's what they did. So, and also having a larger size, a larger body mass index, and that's probably because they were linebackers. So, other places that there have been MRSA outbreaks documented include daycare centers, schools, and of course in gyms using the workout equipment. So now if you go to a gym, they often will have sprays and wipes. So after you use the gym, you're supposed to wipe everything down. And that's to prevent MRSA transmission. So specifically in cystic fibrosis, as you know, it's associated with worsening lung function. And actually the data is sort of out about Staph aureus versus MRSA. MRSA clearly has been associated with worse lung function, but Staph is sort of, some say it is and some say it's not, so that's a little bit of a harder call. As we saw before, the peak prevalence is about ages 11 to 15, and MRSA was isolated in about in a quarter of the CF patients. And the good news, the bad news is that MRSA and CF is not the community-acquired kind, but has been found to be the hospital-acquired type, where it's more multi-drug resistant. And that could be because of different things. One is people with CF tend to have more exposure to healthcare, so you're more in that environment. And they tend to also get more antibiotics. So it's not surprising that the MRSA they would get would be more likely to be drug resistant. So how is Staph spread? Basically any way you can think of. Direct and indirect, skin-to-skin contact, so contact sports, the football and the trauma, and by contaminated objects. I think also if you even cultured the artificial turf, I think actually you can find quite a bit of staph on the turf. And this was a big issue with me because my husband really wanted to put in artificial turf in our backyard, and I was really resistant to it because of this whole thing. And then I sort of let it go, and then we got artificial turf, and of course everything's fine, and nobody's ever gotten an infection. But I'm a germaphobe, so I think about that. So respiratory secretions also more likely from droplets, not really from inhalation. And unlike other CF pathogens, Staph aureus is something that is really non-discriminatory. It can be passed from CF to CF, from CF to non-CF, and from non-CF to CF. So it doesn't really care. And actually, it's been documented every which way. So that's something that is something to be aware of, but not something to be crazy about, because staph would be passed this way in the general public too. So it's not something that's specific to CF. So just keep that in mind when you turn into a germaphobe like myself. Pseudomonas. So this is the one that, of course, is the most important pathogen in CF, and the one that everybody worries about. Infection definitely leads to chronic and advanced lung disease, and is one of the main reasons for respiratory failure. It's found in up to 80% of CF patients by the time they're age 18. And I do research on Pseudomonas in CF. So I have an NIH-funded grant looking at how antibiotics treat Pseudomonas. And one of the things Pseudomonas does is it makes this very slimy biofilm that sticks to lungs. And this biofilm is really adaptable. So in all layers of the biofilm, if you think of it as a layer of slime, and there's bacteria embedded throughout, you know, the bacteria at the top of the biofilm is very different from the bacteria at the bottom. And so they're able to adapt to different types of oxygen requirements and nutrient demands, et cetera. So they can live in the CF lung for many years. And actually, once the biofilm is established, it's almost impossible to get rid of. So one of the things I've been looking at is how we can better dose antibiotics to sort of penetrate the biofilm early on. And this biofilm is also very antibiotic resistant. It makes a lot of different antibiotic resistance genes, and it can adapt and mutate very quickly. So a Pseudomonas that has one resistance profile at the beginning can end up with a different antibiotic resistance profile later on and do it very, very quickly. But when you look at the strain will be exactly the same. So where is Pseudomonas found? It's basically found everywhere. And in the past, Pseudomonas was associated, again, with healthcare-associated infections in clinics and hospitals, and Pseudomonas is very difficult to treat, and it can be life-threatening. Most of what I do in the hospital is treating Pseudomonas infections. But Pseudomonas is also found in the natural environment: water, soil, plants, dirt. Pseudomonas likes water, so you can find it on a river rock in a stream. It's just out there. It's part of the natural microbiome. In the home, you can often find Pseudomonas on sinks and faucets, bathroom drains, swimming pools, hot tubs, and whirlpools. Just like staph, you can get it in whirlpools. And actually, there is this syndrome called hot tub folliculitis. Has anyone ever heard of that? Yeah, so hot tub folliculitis is basically a skin infection that you get from a poorly chlorinated whirlpool. And you're thinking, why is a whirlpool any different from a hot tub? And the reason is because a swimming pool is very large, and if it's well chlorinated, you can imagine the number of bodies in a swimming pool is spread out sort of throughout this large body of water. In a whirlpool, you often cram like 15, 20 people in this like very small space, and that uses up all the chlorination, and the heat also will break down some of the chlorination chemicals. So it's very difficult to keep them chlorinated. And if you're sitting in a hot tub, you know, it's like part of your spa treatment, right? It opens up the pores, it opens all the follicles, and then if there's anything contaminated in the water, it has an easier portal of entry in. So that's why whirlpools are a little bit more unsafe compared to swimming pools. It's in your salad. Shocker. So the reason I put this up is actually I was sitting in an infection control meeting. This doesn't mean don't eat your salad. I was sitting in an infection control meeting, and we were talking about Pseudomonas. And everyone's always in a big hype about Pseudomonas, and what do we do to prevent it, and how do we prevent spread. And one of our infectious disease pediatric attendings was sitting there, and she said, "It's in your salad." And it really drove home the point that it's pretty much ubiquitous. It's out there. Okay, so there isn't any way that you can absolutely prevent exposure to Pseudomonas. It's just out there. So we can't think about it in the sense that we have to be in a bubble, because there's just no way you can prevent yourself from having exposure. But there are definitely ways that you can minimize this exposure, and it definitely does not mean you shouldn't eat salad. Okay, so Pseudomonas transmission in CF, most likely from the environment. So when they've typed strains, they found that most spread is not through like a hospital or a clinic or from another CF patient. It's from the natural environment, from the water, from the dirt, from just households. Even though we have seen spread through direct contacts in things such as clinics and camps and between cystic fibrosis siblings. So it's usually through droplet transmission, and even in a hot tub, in a whirlpool, one of the things that people were concerned about is if you're aerosolizing, if you have all the steam coming up from a hot tub, and there is Pseudomonas growing in it, could you potentially inhale the Pseudomonas? And it's a potential risk. It's hypothetical. I don't think it's ever been documented, but it's something that people think about. Transmission between CF patients is well known in Europe and Australia in clinics, and they have strains like the Livermore strain, et cetera, that are very prevalent. That hasn't been as well documented in North America. But what I'd like to say about that is it doesn't mean it doesn't happen. In Europe and Australia, they're much more ahead of us in the curve in terms of genotyping their strains and looking at this type of spread. We don't tend to do that in North America, so even though it hasn't been well described in North America, it's probably, one of the main reasons is probably we don't do a really good job of looking, and we don't look as diligently as they do in Europe. Spread from a CF to a non-CF patient is extremely rare. And likewise, from a non-CF patient to a CF patient is also very rare. Okay, Burkholderia cepacia. So B. cepacia, as you know, is made up of up to 17 different species, and the ones that are most common in terms of causing infection within the Burkholderia cepacia complex is Cenocepacia and multivorans. These are the number 1 and 2 species in the complex. The third most common is gladioli, and it is not a B. cepacia complex, but it's still a Burkholderia species, which is why I put it there. And we are very concerned about this organism because it can lead to very rapid decline in lung function, and it has been shown to increase mortality. And for the most part, having Burkholderia will exclude patients off the lung transplant list. This is something that may vary a little bit from center to center, and I think actually at UCSF, I do remember we did transplant a person with Burkholderia before, although it's not a common thing, okay? Because the increased mortality before transplant also carries forward even after transplant. So where is B. cepacia found? Basically everywhere you find Pseudomonas. So it's just out there, and it has also been associated with many healthcare-associated infections. It's a very hardy organism, and one of the ways that I can highlight that is, I don't know if many of you remember in late 2011 and early 2012, there was a massive recall of antiseptic wipes because the antiseptic wipes were contaminated with Burkholderia. So if you think about it, they were actually living in the wipes, okay? So, and it wasn't alcohol gel, it was benzalkonium chloride, and that's the type of thing that you see in things like handy wipes or wet ones, so those type of wipes. So benzalkonium chloride isn't great against gram-negative organisms like Pseudomonas and B. cepacia, and that's why they were finding B. cepacia growing in those wipes. It's also found, again, in the natural environment, in soil, plants, onions, and everyone talks about this root rot, like should you eat onions? Should you eat a moldy onion? I would eat onions. I would not eat a moldy onion, regardless if I had CF or not. So just keep that in mind. If you see it sort of an out-of-date onion, I would probably check it. But I don't think having CF or not CF makes a difference. So B. cepacia transmission in CF, as you know, there have been documented outbreaks in summer camps, retreats, and clinics. It can be spread through droplets, through direct and through indirect contact. So general infection control recommendations. So the one thing I want you to get out of this is to realize that most infection control applies to everyone, not just people with CF. And these are sort of the overarching guidelines. Always have good hand hygiene. I always carry hand gel with me wherever I go. Always use standard precautions no matter what, okay? And that doesn't matter if you have CF or not. Cover your cough and sneeze. Stay away from sick contacts. It's very important for CF patients to stay away from sick contacts, but when my children were very young, anytime there was somebody in the house that had the flu or had a cold, they definitely stayed away from them. So it didn't matter if they had CF or not. Cover your cuts and scrapes. I know that sounds really basic, but scrapes can be infected with staph, and you want to keep them covered, especially if they're oozing, okay, to prevent transmission. And don't touch anybody else's cuts and scrapes. The thing that makes me crazy is you go to a swimming pool and you see like a Band-Aid on the side of the pool. That makes me nuts. That makes me nuts. Avoid touching your eyes, nose, and mouth, again, because you can have droplet transmission through all your mucous membranes. Don't share personal items. Don't share the same toothbrush. Don't use the same razor blade to shave. Family members drink out of the same cup. I would probably not do that, especially during flu season. And get immunizations. So not only just the people with CF, but everybody in the household. So the person with CF getting immunization protects them, but having everybody immunized also protects them. Okay, so that's also very important. CF-specific recommendations. Be proactive. Educate others about CF and infection control. If you sell it to them as, you're protecting my child as well as protecting yourself, I guarantee you people buy into it. Okay, nobody wants to get infected. Always know your respiratory cultures, and that's important for events like this, so you know what your risks are. But also, knowing your cultures is important for you in terms of knowing what your risks are, and if you are in contact with someone else who has cystic fibrosis, if you are at an increased risk to somebody else. Avoid face-to-face socializing, and it sounds like the new guidelines are going to say maintain a distance of 6 feet. So before it was 3, and then it was 3 to 6. I think it's now going to be 6. And the same guidelines apply regardless of lung transplantation. So even after receiving a lung transplant, all the same guidelines apply. And actually, you should be even more stringent with hand hygiene, because having a lung transplant means that you will be on medicines that will prevent you from rejecting your lungs, and those will put you at even a higher risk of infection. So really important to get your immunizations, stay away from sick contacts, using hand hygiene. So let's talk a little bit about special situations. Again, it's a balancing act. So living in a bubble is one extreme, and then doing nothing is the other extreme. And just like anything in life, this is a balance. And this is a balance you have to work at every single day with every single activity. And realize that the goal of infection control is not to prevent infection, because even the best infection control won't prevent all infections, but it will reduce your risk. And so this is a balance between living in a bubble and having a fulfilling life. And remember that quality of life is really important. That's part of living. So take that into consideration. You might have to give a little on some things, and maybe you'll be really strict on others, and that's okay. So you have to sort of find where your barometer sits and go with what's comfortable with you. In the home, common sense should always prevail, okay? And again, whatever applies to CF should apply to non-CF. If you have CF siblings in the house, try not to share things that touch mucous membranes. So don't share toothbrushes. Don't drink out of the same cup. Don't share respiratory equipment. And if you need to do respiratory therapy, do them in different rooms and at different times. And that's, again, because of this whole spraying thing. So if there's any type of aerosolized bacteria, that can be prevented from crossing into the other room. It's unreasonable to separate SIBs. And it's also unreasonable to have 2 sets of everything. You can't have 2 sets of toys, 2 computers, 2 iPads. It's too much. But what you can do is if you have a family that has more than one CF person in it, wipe down your iPad in between use. Wipe down the computer. Get these wipes, Clorox wipes, and be a little bit more vigilant about that type of thing. Maintain a clean, dust-free environment, but don't go crazy, okay? So when I mean by a dust-free environment, we're talking now about the particles that can fly in the air, the droplet nuclei, and other things that can carry on dust include molds. So aspergillus or some types of yeast. So if you keep a dust-free environment, that will minimize the molds, okay? And this is sort of goes along the same recommendation as what do you do if you have to renovate your kitchen. So it's probably a good idea not to have a CF person around when you're blasting out the walls because of all the stuff that can blow around. And Pseudomonas in the home usually is found in drains and showers. So that would be a place where I would probably spend a little bit more time cleaning. So the drains, the faucets, anywhere where there's water going down. And as a side note, I teach a class at UCSF on over-the-counter use, and I always have this friend of mine who's a dentist come and talk about dental products, and her biggest pet peeve is anybody who sits the toothbrush near the toilet. Because the toilet, every time you flush, aerosolizes stuff into the air, which you can't see, but of course happens. So don't store your toothbrush and your personal items above the toilet. Put them aside, a few feet away. Close the toilet before you flush it, and that will minimize the spray. At play. So let kids be kids. Kids are going to get dirty. They're going to get scrapes. They're going to fall and hurt themselves, and it's okay. They're kids. Okay. Let them play sports. Let them have lots of non-CF friends. Okay. And when they play sports, they're going to be active. They're going to be running, and that's good for their lungs. Pets are absolutely okay, and actually, pets are a good thing because for a lot of children who feel isolated from all these restrictions with CF, pets are a real good big comfort to them, okay? And yes, in the literature, they have shown that some pets can be colonized with staph. But you know what? I'm probably colonized with staph and you're probably colonized with staph. So it's okay. I would give them a pass on changing the kitty litter though, because again, when you change a kitty litter, there's probably dust blowing up, and that could be a risk. Chlorinated swimming pools are okay, and if you're like me, you always smell the chlorine, and that's comforting. If you can, sometimes when I smell the chlorine, I think that's probably over-chlorinated, but at least that you have a sense that there's enough chlorine in the water. Avoid hot tubs if you can. Don't go into whirlpools like we talked about because of the increased risk of Pseudomonas. And that got cut off, but avoid digging around in the dirt, in the mud. So, if you're into gardening, that might be something you want to think about not doing. And last month, I even read an article about a mother in the UK who had 2 children who attended a school. And she actually decided to pull her children out of the school and homeschool them because the school was going to plant a vegetable garden. And she thought that would be an increased risk to her children. And I really thought about that. And it probably could be an increased risk, but that could also be an activity where they don't participate in. So choose your battles and realize where you set your barometer and do what's comfortable for you. At school, communication is really important. Communicate with teachers, administrators, parents, kids, okay? Provide the alcohol gel. We have, the liter size in the kids' classrooms. Use the antibacterial wipes. Buy them for the classroom. It's a small investment. Remind them that good hand hygiene benefits everyone, not just the child with CF, but everybody in the classroom. Separate kids with CF into different classrooms. If it's a CF SIB, it's probably okay. And that's your personal choice. Some parents don't like to have their SIBs in the same class anyway because they sort of pick on each other. Use separate bathrooms and water fountains. And actually, what I would say is don't use the water fountain. Send them bottled water. The water fountains at the schools gross me out in general. So, and I read a lot of papers on infection control, and you always read the paper how they went and swabbed all the water fountains at a bunch of elementary schools, and they grow E. coli and fecal matter and whatever. So I personally just send them with bottled water. And assign separate desks or stations to keep kids separate. In the clinic or hospital, so I'm not really going to touch about this, but just realize that in general, wear a mask, stay at least 6 feet apart from others, and bring your own things to keep the kids busy. Each hospital is going to have their own separate policy, and you should abide by each hospital's policies. Everyone gels in and gels out, even if they don't touch anything. And what that means is you go into the hospital, you gel in. You go into an exam room, you gel in. Even if the person coming in doesn't touch you, doesn't touch the table, doesn't touch the sink, touches nothing, they should gel in. And when they leave, they should gel out, okay? And it's absolutely okay to ask your healthcare provider or other hospital personnel to wash their hands or use alcohol gel. Be proactive. If it's a reputable place, they will not be offended. And if they are offended, you should go straight to their supervisor because it's in your best interest and it's in their best interest. So everybody gels in and gels out. Not just the healthcare providers, the social worker, the visitor, the sibling, everybody. Coping strategies. Stay informed, communicate with their CF care team. Talk with the social worker. If it's getting to be a problem, help and get some tips. They'll have a ton of them. Young children are the easiest group of people. They're very malleable. They adapt to basically anything. And they're easily distracted with toys and games and crayons. Bring your own video games to the clinic. And at home, have structured daily activities. Have a routine for them. School, after-school sports. Just schedule everything in, and that helps. Older kids and adolescents are the worst group. They are the hardest groups just because they're teenagers. They're going to rebel. They think they know better. And this is the age where they're exploring. They're trying to find out more information about themselves. They're looking for friends that understand them. And so they really need that support. So structure is very important for them. Have them stay connected. Chat rooms, texting, Skype, FaceTime. Those are all important ways for them to stay connected with their friends in a way that's not going to increase risk of infection. And again, TV and music is very important. A necessary evil. So when parents were asked about infection control measures in a hospital, this is basically what they said. It's a necessary evil. And for the most part, parents and children agree with these hospital segregation policies. They understand that this is what they need to do to stay safe. But when you ask them, how did it make them feel? Kids were more likely to say, I was bored, I felt lonely or anxious because I couldn't leave my room, I couldn't talk to anybody, I felt stigmatized, I don't want anybody else to know, and they had a very negative view of this. This was very different from the family members and the parents who had other anxieties and stresses that they needed to worry about. Because their children couldn't leave the room, they felt pressured to visit them all the time, to stay in the room, to keep them engaged, to keep them occupied. They felt responsible for their children feeling bad, like we all do. And it was a big disruption to their routine, and a lot of parents had difficulty with work. They felt like they had to be in the hospital all the time, and for some, if it's an extended stay during exacerbation, they can't work. And that added an additional level of worry or stress to the parents. And these are all things that I want you to think about, because if you are feeling this way, this is when you need to talk to your healthcare provider and talk to the social worker and your CF care team. So lastly, I have a few other things I wanted to show you. One is some reputable infection control resources online. And of course, you have the CFRI and you have the Cystic Fibrosis Foundation. And has anybody ever gone on the CDC website? Yay. So everybody at the end of the day should go to the CDC website. This is a great website, and it's very infectious diseases focused. And part of the reason for that is because the past director of the CDC was an infectious disease doc from UCSF. And so that became her mission. She made it a lot more information about infectious diseases, about staph, immunizations, pneumonia, et cetera. So you can search for any type of infection on this website, and you can find information about it. This is another website from the CDC. This is a page from the CDC website. Anybody ever gone to this website? This is a fabulous website, and actually I'm going to try and hyperlink it over to show you what it looks like. So this is a travel website, and basically for anybody who was traveling, this gives you all the information you want to know about travelers' health. And what you can do is you can actually put in here any destination you want to go to, and it will tell you what immunizations you need, whether or not you need malaria prophylaxis, what are the common infections there, is there a risk for rabies, can you get African sleeping sickness, etc. So it's a great website to look at before you go on vacation. There are also really great tips about when you travel, what to do with your medicines, what to do if you get sick, etc. And who likes to go on cruises? Anybody been on a cruise before? So there's also this, I just came back from a cruise with my family, and being a germaphobe, I went to this website called CDC Vessel Sanitation Program. And basically, you can look up any cruise ship and see how clean they are. So, which is what I did. So you can go to this website and put in, your Royal Caribbean or your Disney or whatever, and see how they rank. And it'll tell you what the violations were, and when was the last time it had an outbreak of norovirus or whatever. So it's sort of fun, but it gives you a lot of good information, and I like it. Okay. And lastly, a word about hand sanitizers and antibacterial soaps. So all hand sanitizers are not created equal, okay? Stick with the alcohol-based sanitizers, and you need at least 60 or 62% for it to be effective. And this is one of the things where more isn't necessarily better, so look for a percentage of about 60 to 80. Once you get about above 80, interestingly, it starts to work not as well. And the reason being is because the way alcohol gels work is they need some kind of water involved for it to spread around and to be active. And when you get into these high concentrations above 80%, there's less water. So when there's less water, they don't work so well. And it's also very drying on your hands. So stick to the 60 to 80% range. You don't have to go crazy. Don't pour the pure alcohol on your hands. Okay? There's less data with the natural sanitizer. I know it sounds very attractive because you're not putting chemicals on your hand all the time. So things like tea tree oil and thyme oil, where you can get them at Whole Foods. They sound attractive, but there's less data on them, and we don't know how well they work. And there's not a lot of good head-to-head studies. In terms of effectiveness, alcohol is best. Other antiseptics, such as benzalkonium chloride and chlorhexidine, also work, but they're not as effective as alcohol gel. And actually, benzalkonium chloride, remember, was the one where it had Burkholderia growing on the wipes. And surprisingly, alcohol gel is better than hand washing. But if you have hands that are visibly dirty, that have dirt on them or debris on them, wash them first, okay? If you have debris on them, no amount of hand gel is going to help. And the last thing about the hand gels is, you can get these really cute hand gels now if you go to places like Bed Bath & Beyond and Body Works, where you can get the foams and you can get ones with cutesy things floating in them, and they all smell like raspberry or strawberry or whatever. Look at those. Look at the ingredients before you buy them. because a lot of the foams will not be alcohol. They'll be benzalkonium chloride. And so you really want to stay with the alcohol hand gels. And I'm not so fond of the kind that have the scents in them, just because you're putting this on your hand a lot, all the time. And you want to minimize any potential for contact dermatitis or rashes. And because they have scents in them and they have cutesy things in them, you could potentially get an allergic reaction, and you want to avoid that if possible. So stick with the basics. And also, lastly, these the cute hand gels, they look really yummy, and they smell really yummy. And so for very small children, they look like food. So you want to minimize any potential for accidental ingestion. So a plain bottle of hand gel doesn't look all that appetizing, but one that has a strawberry on it or a raspberry on it, smells like fruit, might actually be accidentally eaten. And lastly, antibacterial soaps. Those are really popular now. You can get triclosan soaps. You can actually get triclosan embedded toys that are supposed to minimize bacteria on things that kids put in their mouth and such. Or you can get triclosan embedded food containers for school. And I'm not a big fan of those. We don't have a lot of data on those, and my personal opinion is we should not be exposing all the potential bacteria out there to all those antibacterials if we don't need to, because they can then become resistant, and actually there is a potential for increased resistance for Pseudomonas with the antibacterial hand soaps. Okay, so lastly, the last thing I want to do is just show you a short video on hand gelling. And the reason I have this is because we always talk about how to wash your hands, and you have to whistle or do the happy birthday thing, but nobody really talks about what's the proper way to hand gel. People just slap it on their hand, they do this, and they're done. And it's really not that simple. So to really properly use hand gel, it should take you about 15 to 20 seconds. So I'm going to play the video, and let's see. Okay. There's no sound. It would be best. But I can narrate too. So do you see how she's applying it on her wrist and back and forth, and sort of getting the fingertips and doing this on your hands? So sort of digging your fingernails into the palm of your hand to get the part underneath the fingernails and doing this. So I think that's the part we miss. Underneath the fingernails and in between is really important, and of course up on the top of the wrist. And how long should you use hand gel for? So if you put about a ml or so of hand gel, it will take you about 15 to 20 seconds for it all to evaporate. And you want it to all evaporate. You want to keep rubbing until the whole thing evaporates. And that's really the key. Okay, so in between the fingers, up at the top in the fingernails like this, and doing it on your palms to get really underneath the fingernails. And like I said, you should do it for the entire time until your hands are dry. So one of the last things I wanted to say is, people get concerned about, I'm using all this hand gel and my hands are getting really dry. What do I do? So you should keep using hand gel. And when you wash your hands, one of the ways to prevent your hands from getting too dry is don't use hot water. There's no difference between hot water and cold water in terms of antibacterial effect. It's equally the same. Don't scrub your hands. When your hands are washed, don't rub them with a paper towel. Pat them dry. Okay, just pat it lightly and let it dry. Same with the alcohol gel. Okay, and definitely lotion in between hand gels has been really important in terms of keeping hands from getting cracked. And you don't want your hands to get too dry, because having your hands get cracked or open up is also going to be a source of infection. Okay. And studies have shown that if you can get people to keep using hand gel, one of the things that is equally important is giving them lotion. If you give them lotion and their hands stay nice and soft and not dry, then they'll be more likely to stick with the hand gel. Okay, and I'm not going to go over the hand washing because I think you know that, and we don't have the sound anyway. Any questions?
Yes, thank you so much for sharing your thoughts on how to address infection control. Thank you. We are having a Q&A right now, so those folks that want to do that, please line up, and we'll start with you.
Thank you.
Oops.
Fantastic talk. But how do you get the sinks and drains clean from Pseudomonas?
That's a great question. I don't really know the answer to that. Using Clorox, using a bleach solution, I think is pretty much all you can do in the household. If you look at the studies on biofilm and in water tanks, they use pretty sophisticated techniques to sort of get the slime off, and that's really what you're talking about. In the household, it's really just using your household cleaners and your bleach is pretty much going to be it.
So the fourth source of infection control would be my wife. When she goes to the grocery store, she hand gels everything.
Yes.
She always worries about going to the bank and the money. Uses
Yes.
her own pen to sign instead of their pen.
I can understand that.
So,
Yeah.
and how many times a day do you have your husband hand gel the backyard?
So I have to say, one of the things that makes me crazy is when you go to the airport and my kids like to run their hands along the walls or on the escalators. It makes me nuts. And, I always carry hand gel in my carry-on. I put it in each one of my kids' carry-ons. And when they were very young, when they were babies, I used to actually carry the handy wipes, and when they sat down in their seat, I would sort of give the airplane seats a quick rub over. I sort of let that go now. But like I said, there's no way you can do everything. We try.
I have a 26-year-old son with cystic fibrosis, newly married.
Great. That's great.
If he has a child, a newborn, what is the risk for a non-CF newborn from any bacterial resistant things that he has?
Right.
What kind of precautions?
That's an interesting question. I don't think anyone's really ever looked at that, but from a common sense perspective, as long as the baby is healthy and does not have any type of immune deficiency or a compromised immune system, their risk should not be any higher than any other newborn. So things like kissing, if a father with CF kisses the newborn, could you transmit CF to the baby? I guess there is that potential risk. I don't know if anyone's ever documented that. I've never heard of that.
And same too, like with his wife. I know when they were dating, she had asked me, is there anything I can get from him?
Oh, and she does not have CF.
Correct.
Yes, it's very uncommon to have something passed from a CF person to a non-CF outside of staph. So staph and probably respiratory viruses are the only thing that I would think of would be your things that you could normally pass. But specific things to CF, such as Pseudomonas, Burkholderia, even non-tuberculous mycobacterium, no. There's been I don't think I've ever seen a case or even heard of one.
Last one, sorry. If he's cultured MRSA, but then another culture comes back non-MRSA, is it there and quiet and sleeping, or is it gone? Like Pseudomonas will be there, and then all of a sudden it's quiet and sleeping, maltophilia, all these sorts of things. It's still there, it's just not as high maybe in number nature?
Yes, that's a great question. And so there are studies where people have decolonized patients with cystic fibrosis, who have cystic fibrosis and MRSA, And we do occasionally do that in the hospital for non-cystic fibrosis patients who have MRSA. Because, and I can tell you one of our common scenarios is a person who has either MRSA colonization and some kind of hardware infection. And they tend to keep getting hardware infections, say with an implanted knee or an implanted hip. And so in those cases, we will try to decolonize them. It's not a permanent fix. So you can decolonize patients during their you can decrease the load, but people who get staph tend to just recolonize, and it's really hard to permanently decolonize a person from staph.
So the answer is yes then, if he has cultured MRSA, but it doesn't show up on the culture next time, it's still there?
Who knows?
Okay.
It probably is not there at that point, but it might pop up later. It's not quiet, it's not sleeping, it's gone.
Okay.
But it may come back.
Okay, thank
Yeah.
you.
It's on her.
Thank you. That was very informative. Staph is a problem in young children, as your graph showed. Now, how does UCSF eradicate, and what's the protocol in your dosing to eradicate sensitive staph, or MSSA? And are you using some kind of fusidic acid or a different, something similar to fusidic acid, which Europe is using in
Right.
success in a combinational therapy?
Right.
Lastly, could you comment on the new changes for staph treatment or protocols coming out of the foundation?
So the first question about decolonization, that's actually a tough question because there is no across-the-board guideline for how to decolonize a person with staph, regardless if it's CF or non-CF. I think that's something we just grapple with. The Copenhagen study that you're talking about, where they used, I think it was fusidic acid and a beta-lactam, and they used something like 2 weeks on and then maybe 2 weeks off or something like that. There's some kind of cycling. We do though, you can do that on sort of a case-by-case basis. I don't think we have a protocol for that per se. And if you look in the Cochrane collection, which is the Cochrane collection is basically a body that looks at evidence-based guideline and tries to take all the evidence from different studies and come up with one sort of recommendation. When they've looked at all these studies, there isn't any sort of standard approach. There's no standard approach to colonization, and it's very, it's hit or miss on whether or not it works. So whether or not you decolonize a patient sort of is, I think, an individual thing. And the second question was about?
The foundation's new guidelines on staph.
I'm not sure if I know what that guideline is.
Oh, you introduced that in the beginning of your talk.
Oh, the new guidelines on infection, I'm thinking about treatment. So, the guidelines on staph are really interesting. There is no CF guideline for staph. So the guideline for staph is really going to be taken from what is known about the general public. So there's very little data on how to prevent CF transmissions, or studies done specifically in CF. But those studies are done in general population. So that's really where I think the guidelines are going to come from. Not specific to CF, but just staph in general.
I was looking for specifics, nothing yet.
I'm sorry?
I was looking for specifics on the new guidelines. There's nothing yet.
I'm not sure I think we should wait till those guidelines come out. I don't want to talk about those too much yet.
Dr. Yang will be here for the Ask the Experts panel. We probably have time for 2 or 3 more. I don't know that we'll have time now for any more.
Wait, so what?
You're in. Go.
Okay. I have a question about B. cepacia. You mentioned there were 17 distinct species, and from what I know, not all of them really kill you as much as other species do. I was wondering if you could tell us a little bit more about that.
About the ones that are more...
Well, about which strand, what sorts of different strands there are and what that means. Like if you culture B. cepacia, which one is the terrible one and which one's like the one in the family?
Yeah, I think mainly it's going to be those top 3 that we talked about are the ones that are most common and have been shown to be most virulent. So it's going to be those top 2 that I had up there.
Hi, you spoke of, I have a 4.5-year-old with CF, and you spoke of water fountains.
Yes.
How do you convince the older population not to drink tap water? To give my daughter, I feel like I'm always like, my mom wants to give my daughter tap water, and I like panic.
Yeah.
So is it okay to drink tap water from your home? I know it's a different, I just feel like I always have to do bottle, and she's like, Karen, I don't understand. She's drinking tap water.
Well,
I
so
feel like
tap
there's always
water,
this, like,
tap
fight,
water
like-
is interesting because, so you can always buy an inline water filter for your tap water, but that's not going to filter Pseudomonas.
Right.
And the reason is that Pseudomonas is going to grow on the tip, or it's going to grow on sort of where the water is coming out, or it's inside the piping. So your filter could be down here, and then you still have the piping coming up into your, coming out, and you could have the Pseudomonas in the piping. So that is sort of why the recommendation is not to use tap water for things like cleaning your nebulizers, et cetera. Like, don't do the final rinse with tap water, because whatever's coming out of the tap, even though it's filtered, could still have bacteria on it. And when they do testing of the water fountains, for instance, what they basically did was go and swab where the water comes out.
Right.
And that's where they found all this thing like, E. coli and all kinds of coliform bacteria.
Okay, yeah, all right. Because, I feel like I'm always like in a battle. Like, don't give it to her, don't give it to her. And she's like, but I don't understand. You grew up on tap water, but I didn't have.
Yes, and we did grow up on tap water. And I think actually tap water is important because of the fluoride. I mean, because if you drink bottled water, kids are going to be more at risk for things like cavities because there's no fluoride in the water. So tap water is definitely important, but for the majority of the population who have intact immune systems, who are not at risk infection, tap water is perfectly fine.
Okay, thank you.
I'm from Houston, where we have about 90%, over 90% humidity most of the time, most days. And I have a 20-month-old granddaughter, and her parents are 20 and 21, and they both live with me. And they are really obsessed with water right now, and getting our granddaughter into water tubs and different things. Mm-hmm. And one of the things that I was able to convince them not to do was take her to the outdoor water parks, because I called the Parks Division, and after seeing an article in the local paper that said that E. coli was found in several of the parks, systems. And so then I started thinking about the spray, coming from the water parks. And then also I thought, well, we may have something going on in our yard, in our hoses and things like that. So then I became concerned about, the outdoor, tub pool. Should we chlorinate it? Should we not? Then I found online from the UK, there's a filter called, it's supposed to get rid of Legionnaires and Pseudomonas. I don't know if you've heard about that, or, and so I was wondering what your thoughts are on trying to filter things.
Yeah. So now we're getting into the bubble. So, and that's, for every one of these scenarios, I think we have to remember there's always a risk. There's a theoretical risk. Water coming out of a municipal water park is not going to be chlorinated, right? And yes, there could be Pseudomonas. There probably is Pseudomonas in it, just like there probably is Pseudomonas coming out of your hose or whatever. The thing we have to remember is, there's no way we're going to be able to eliminate all of that. And for your granddaughter to say, don't go to the water park, don't play in the swimming pool, whatever, that's going to be a risk balance, I think. There has never been a study that has looked at, so remember, everything in medicine is going to try to be evidence-based. And there's never been a study that has ever looked at municipal water parks and whether or not the Pseudomonas or E. coli coming out of that causes an increased risk in transmission of Pseudomonas. There's never been a study. So yes, there may be Pseudomonas coming out of there, but we don't know if that actually does lead to increased risk. That's sort of the bottom line.
All right, I haven't heard this one being asked. You're in the hospital or you're with someone who is in the hospital bed, and the technician enters the room with rubber gloves on. Where have those gloves been? And what do you say diplomatically? And what is the situation with rubber gloves?
So rubber gloves are great because they can protect the person who's wearing them, but you don't know, as you allude to, where those gloves have been. If I had a person coming into my room who had rubber gloves on, I would feel no qualms in saying, take those gloves off, alcohol gel your hand, and if you need to, put on a new set of gloves, take them off the wall right here. That's what I would do. What if the person says, oh, I'm just going to alcohol gel my gloves? No, right? You said, are you nuts? Get out of here. So you would say, take the gloves off, alcohol gel your hands. If you need another set of gloves, put on a new set of gloves.
Thank you very much. One more time. Let's hear it for Dr. Yang. And we'll see her again this afternoon during the Ask the Experts.